Hi, everyone. I'm Paul Wada. I'm a first-year fellow at Vanderbilt in infectious diseases. I'm going to be talking today about site-level comprehensiveness of care and individual clinical retention in adults with HIV, part of an IeDEA collaboration. For retention and care, we looked at sustained regular care, and this is really an essential core component of the HIV continuum of care. For comprehensiveness of care, this was a range of services to meet a patient's healthcare needs. And we wanted to look specifically to see if comprehensiveness in care was associated with individual level retention. We looked at 7 different measures for comprehensiveness. They included ART adherence, nutritional support, prevention of mother-to-child transmission, CD4 testing, opportunistic infection screening and management, prevention services, community outreach, and that included patient tracing. We included data from all 7 IeDEA regions. Adults age 18 years and older with HIV were enrolled in treatment and care programs. And if they responded to either site assessment 1 or 2, they were included. Site assessment 1 was 2000 to 2009. Site assessment 2 was 2010 to 2016. We excluded all the pediatric patients and any person time that was contributed in the year of death or in the final quarter of the year of enrollment, because that wasn't really at risk for retention. This is a map just showing you the widespread nature of IeDEA and just how many different sites we had involved in the study. Our comprehensiveness scores range from 0 to 7, 7 being the most comprehensive. For retention in care, you needed to complete at least 2 separate visits or get at least 2 different lab measurements more than 90 days apart within a calendar year. For loss of follow-up, this is more than 12 months since the last visit before the study closed. We had 2 definitions for this that included either as at risk for re-engaging in care until death or end of study, or we censored them at the first gap without clinical contact of more than 12 months. We wanted to see if there was really any difference between the 2. For additional factors, we modeled adjusting by age, sex, and calendar year with fixed effects by IeDEA region. And for our sites, we nested all the individuals within each site. We used modified Poisson regression clustered by sites, and then our comprehensiveness scores were modeled using categorical indicators. Getting into the data now, we had more than 277,000 individuals in care. This was across 103 sites with 1.1 million person years of follow-up, very robust. 79% of person time was retained, and this varied across regions. Our lowest score was 63% for Asia Pacific, and highest was 91% for East Africa. Every site seemed to provide CD4 count testing, and what we thought was fantastic was more than 90% of individuals received care at sites with ART adherence, PMTCT, opportunistic infection screening and management, and HIV-related prevention services. For retention overall, it did improve 2% per year over the course of the study, which was statistically significant. In our adjusted models, individuals at sites with more comprehensive services did have higher probabilities of retention. It was statistically significant for the trend. 70% of sites with scores of 5 had clinical retention, 80% of sites with scores of 6, and 85% of sites with scores of 7. This graph is really laying out what we just previously talked about. As you can see here, there is some overlap in the confidence intervals. So say between scores of 5 and 6 and 6 and 7 might not be statistically significant, but overall the trend for comprehensiveness did show statistic significance. There were a few limitations to our study. Several of the regions did not provide complete information on transfers, and for Asia Pacific in particular, we had to proxy visit dates from the lab testing because we just didn't have available information on visits. For the analysis part of things, there could be some misclassification of outcome. We may have measured transfers of care as not retained or loss of follow-up. In reality, this is probably a very small number. Incomplete mortality ascertainment was possible, and few sites had comprehensiveness scores less than 5, so we were limited in our ability to assess association between all of the scores and clinical retention. So in conclusion, within IeDEA, we did see greater site-level comprehensiveness services associated with improved clinical retention. I just want to thank everyone involved in the study, particularly the patients, staff, researchers, and the IeDEA sites. and especially Dr. Peter Ribeiro and Ara Kim for all their work on this project. Thank you.